Hello, this is Steve DiMarino from Musculoskeletal Specialists in Los Alamos, New Mexico, and this is the theory portion of our manual therapy and exercise introduction class. This is physical medicine beyond muscles and fascia. And so what do I mean by physical medicine beyond muscles and fascia? And so there are 7 systems that a manual therapist must be able to navigate to be an effective practitioner. So you got muscles and fascia as one of those systems. You got to be able to work the ligaments, joints, and periosteum. Now, I know that all of these are fascia. Your whole body's fascia. But what we're talking about is splitting these up. When I'm talking about muscles and fascia here, I'm talking about muscle contractions, the neurological contraction of a muscle. I'm talking about muscle balances. And the fascia that I'm talking about here is more of the anatomy trains fascia, like this piece of fascia goes to that piece of fascia and how it all connects and where things go. We're going beyond that now. We're talking about how the system functions, okay? And so muscles and fascia is number 1. And then number 2 is ligaments, joints, and the periosteum. The periosteum is the membrane around the bones. And if that gets too tight, the bones get locked down. And this is going to make sense in a second when we explain nerves. So nerves, veins, and arteries, you have to know how to work those. You have to understand how to work the dura. The dura is the membrane around the brain that goes down through the center of the spinal cord. And of course, is connected to all the nerves all the way out to your periphery. You have to understand how to work the viscera. These are all your organs and the ligaments that connect the viscera. And then you have to be able to do exercise, because if you just do manual therapy to correct the physical body, you haven't really changed the system because it's still functioning the same. You have to change the way the brain communicates to the body to make a real change. And that involves patient participation. And the 7th system is the brain vagus system, the trauma system. And this is treating the brain and the trauma. Say you sprained your ankle when you're a little kid and you twisted it really hard. Well, every time you step on that ankle, the brain could go into a low-grade fight or flight, and that could be continuing for 50 years. And so tight muscles could be occurring from that brain system, the trauma system. And so you have to know how to treat that. And we have a very effective treatment for the vagus system. Okay, and so if you want to know more about each one of these 7, you can go to our website here, mskspc.com, click on the practice, go to video education, and then go to what we do. And there's an hour and 10-minute video that we have for our patients that explains each one of these systems. And then you need to integrate those. Okay, but I'm going to go deeper into it here a little bit. Okay, so these are the rules of physical medicine. Okay, and so physical medicine is advanced manual therapy. This is beyond just rubbing pain spots or working in a spa. These are people come with pain patterns. Your patients have complaints. They have pathologies. They're coming for a solution to a problem, not just to have some their pain rubbed out that's going to come back again. And so what we're trying to do is source the actual problem. And in this headache class, we're not going to just treat the headaches. We're going to go for why the headache is occurring and try to relieve that. Okay? So here's some rules that we have to follow if we're going to treat headaches effectively. Okay? 80% of muscle pain and dysfunctions are sourced from the brain and nervous system. Okay? The brain and the nervous system are the same thing. You have to, don't disconnect those in your mind. The brain and the nervous system are the same thing. Okay? And then number 2, a muscle is tight because the brain is telling the body to guard a nerve, vein, or artery. Now, veins and arteries have nerves around them. And so if there's an irritation on a vein or artery, then your life is in danger. So your brain is going to do anything it can to protect that, because if you lose blood flow, you lose life, right? And so this was taught to me by my mentor and friend, Mark Bookout. And when he told me this, he said, muscles are tight because they're guarding, veins, nerves, and arteries, period. And that kind of went through me, and I didn't really understand that, no, it really is. This is why muscles are tight. And because if you can get your head wrapped around that, you can find out why tight muscles occur anywhere in the body. You can trace down the source of that tension, and you could relieve that tension at the source. Now, here's an example. The trigger point here in your shoulder, in your trap, this trigger point that everybody has, and they've got the cane and they're pushing on it, and you've worked that a million times. That is a trigger point that's related to the accessory nerve. The accessory nerve comes out here, it goes to the trap, and it goes to the SEM. So who has tight SEMs and tight traps? All of your patients or clients. I'm going to call them patients because in our clinic, we're working with pathologies. We work with a team of doctors. We call them patients. So patients, clients, it's the same thing. And so the accessory nerve is causing irritation here. You get this trigger point. So what we do in our clinic is we release this trigger point without ever touching it. And then we know that we actually solve the problem. And the problem is the accessory nerve. And so what we're going to show you here is how to do testing of each nerve, how to do testing, and then how to find in the body exactly where the impingement or the restriction on that nerve is and relieve it at its source. Now, that's the goal. That's advanced manual therapy. Okay. You have to know anatomy to do this, but it's really worth the journey. It's worth the journey because your effectiveness goes through the roof. You're not smashing on people anymore. You're protecting your hands. You can do this work when you're 90 years old, right? You just get better and better with time and more effective with time. Okay, so trigger points are a guarding action happening from a signal from the brain. Okay, so we're not treating trigger points directly. We use them as a data point to go, okay, where is this trigger point source from? Where do I go to fix it? And you use the trigger point to know if the patient's getting better, worse, the same. You keep palpating the sore spot. It's like, is that better? As you work, say, the accessory nerve, and you can keep going back. And once this is gone, you know you cleared the nerve. So they're incredibly important information for you. Okay, the law of Hilton. Say this is nerves that supply muscles, also supply the deeper joints under that muscle, the organs under that muscle, and the skin above. Right? And so we're trying to treat the nervous system. If you've got some deep nerve problem, within the liver and you can't get to it, well, if you know where that nerve is going, you can treat that nerve from distal places. Very effective, very effective. And this is a very good diagnostic, this law of Hilton. Okay, Wolff's law. Okay, if a load on a bone increases, the bone will remodel to become stronger and more resistant to forces. So that's why weighted exercises is good for your bone density, right? If you have osteopenia or osteoporosis and you're exercising in a swimming pool, that's not going to get it. You need weights, right? Because that creates the piezoelectric effect within your bones and it attracts the minerals to it and the density comes on. But what Wolff's law also explains is bone spurs, right? If you have clients or patients, and I'm going to use patients throughout this whole talk, but if you have patients with bone spurs all through their neck, right? And you got to think, okay, why does that happen? Well, if there's an increased tension on the spur, a continual pull on the spur, the bone is going to remodel to accommodate that tension. It has to get stronger. It's got to get stronger and thicker where that bone is getting yanked on. And so eventually you're going to have a pull and you're going to have a spur. Okay, so bone spurs are signs that there was an asymmetry of a joint or an area for a very long time. Okay. Asymmetrical tensions on any joint cause bone spurs, osteoarthritis, and dysfunctions in distant structures due to improper stability patterns. Okay, so anytime somebody says, well, I got osteoarthritis in my hip, you know automatically that there's an asymmetry to that joint. And so to bring symmetry back to that joint, you first must stabilize the core, get core stabilization going, and then you can stabilize the hip and get that joint centered. We call that centration. Okay. Pain is in the brain, not the body, right? Pain is in the brain, not the body. So if you cut your head off, you won't feel pain. If you cut the nerves to your head off, you won't feel pain. Pain is an interpretation of a signal from your body. And so say my finger is cut. If I think that's no big deal, well, that's not going to hurt. But if you're a manual therapist, and you know this, if you're a manual therapist and you get a cut on your finger, when That's a very important part of your body. It's your livelihood, it's your ability to heal patients and help others. And so if you get a cut on your finger as a manual therapist, that's going to hurt a lot worse than somebody who doesn't use their hands for a living because your brain interprets the danger of the cut. And then as it sees the danger, it's like, well, danger is higher. You're going to have a higher pain output and it's going to hurt more. Okay. So patients are in pain. It's not necessarily a dysfunction in the body as it is the brain's interpretation of that. Okay, this is very important to understand as we move forward. If you're not familiar with that, if I told you that and that's not familiar, you need to go on YouTube and watch Pain Science by Mosley and Butler. So Mosley and Butler are two Australian fellows who do really good talks, and they're available on YouTube. You don't need to buy an expensive book. Just watch their talks and you'll fully understand how the brain interprets pain. We've taken that and we put that in our vagus treatment. Okay. So here's our objectives for what we're going to talk about here. Okay. We're going to increase the understanding of the neurovascular anatomy of the head and neck. Right? You got to understand the anatomy to work on it. And with the live class, we're going to take your fingers and say, okay, we're going to work on the jugular. We're going to put your fingers right on it, right? We're going to work the accessory nerve. We're going to put your fingers right on it. If you know where these are, then I hope that you will take these theories and just put them into practice and use this testing criteria, right? That's a game changer. It's absolutely game changer than anything I've ever seen. And I got that test from Mark Bookout. Again, you can look that guy up, Bookout. Okay, understanding the dysfunctional cascade from a whiplash injury. If you have a patient with whiplash ever in their life, you need to understand the symptoms throughout the body that occur from whiplash. And then we're going to talk about how to reverse that. Okay, you need to be able to evaluate and treat the cervical spine with manual therapy exercise with special attention to headaches, whiplash, vertigo, and nausea. Now, in our first intro class, we're going to do the venous sinuses. We're going to drain the brain because it's the most effective, quickest relieving treatment. Also, it's a prerequisite to anything else you're going to do, especially in the vascular system. So it's just the place you want to start. In the advanced classes, we'll be doing more and more specific cervical spine work. All right. So we're going to give a brief introduction to breathing pattern disorders with an emphasis on dysfunction to the neck and head. So breathing pattern disorders, if you want to learn more about that, Leon Scheitau wrote a book called Breathing Pattern Disorders. It is the definitive book on breathing pattern disorders. Buy that, read it. Okay, we're going to learn how to evaluate and treat the cranium post-trauma, right? This is somebody fell and hit their head on the bathroom floor or something like that. Right, this is going to be in the advanced class. The intro class, again, we're going to do all the venous sinuses, which is a prerequisite to everything. Now, I should say this, that the stuff we're going to show in class, typically massage therapists are not allowed into classes with this level of manual therapy because there's going to be a point where the techniques can get dangerous. And so what we're doing here is we're starting with the most simple stuff that's not dangerous, but are prerequisites to the more intense moves, let's say. And I'll explain what that means later as we go. But I'm hoping, because massage therapists are the ones that are doing manual therapy, that we can create this healing process and bringing physical medicine to the public in a much greater way and get this information out there where, we see at our clinic about 500 patients a month. I have a school that I created that is specifically to train new people to work in our clinic because the massage therapists, they don't know enough to work with very specific pathologies. And so we train them from scratch to do that. And so what I'm trying to do here is bring this information into the mainstream and get it to massage therapists because that's the people who are going to be doing this. And they're the people that patients are coming to with these problems. And so that's my hope, that we bring physical medicine into the mainstream and push it. Because if you go see a traditional doctor, an MD, you're going to get a chemical answer to your problem. And the physical answer that they have is a surgical answer. And so, and physical therapists are doing most of the exercise, not much manual therapy. And so, where is the middle of that physical medicine? There's a giant hole in medicine. And my goal is to give information out. I'm giving gold information out here for free. And I'm hoping you can take this and run with it and start helping others, because that's the goal. And I got it from Mark Bookout, who I worked on for a year. I worked on him probably 75 times, and he really taught me a lot. And I'm sharing all of that information with you. Okay, so more objectives. Oops, go back. So the objectives. Understanding how to test and treat the venous system of the brain. We're going to do that hands-on, but I'm going to give you the theory. And if you know where these structures are, pay attention to this theory and go apply it like tomorrow, okay? And your practice is going to change, okay? We're going to learn about the deeper connections of the dura to headaches. You got to know how to treat the dura for everything, especially any association to headaches or sciatica or restless leg or any of these problems, numbness, tingling in your hands. You got to think about the dura. It's very important, okay? Learn how to rehabilitate a breathing pattern disorder. Now, we're going to hopefully teach that in an advanced hands-on class, and because that's going to be a hands-on, but I'm going to give you theory here, okay? So understand the connection of the jaw and its musculatures to the relation of headaches, and then understand the need for rehabilitative exercise to maintain the manual therapy. If I've got somebody's shoulder and it's asymmetrical and it's rotated forward, and they can't raise their arm in the air, that's all they got. You can do the most magical manual therapy on them. They're fully open. It's all beautiful. Unless they have some exercise to bring that shoulder into their brain and reconnect that problem is probably coming back, especially if it's a chronic problem. If it's something that occurred slowly over time, they don't even know how they ended up like that. It's coming back. So the patient hasn't actually learned anything. The brain, the body hasn't learned anything. You've got to get some rehab exercises into the manual therapy and to back it up. And so what we use is dynamic neuromuscular stabilization. That's taught from out of Prague, Czechoslovakia. I would start taking their classes because honestly, I've done a lot of training on exercises, and they are by far the best. It's the most effective system, and it goes into everything that you will do. So it's very adaptive, and it's based on human development, and so it's based on actually how the body works. So that's DNS out of Prague. Highly recommend it. We try to get all of our therapists certified through them. Okay, so why would you do this treatment? Okay, and so a headache treatment is going to be all 7 of those things, but we're gonna work on the venous system. That's our first class. Okay, so headaches, especially a back to front headache, that's probably a cervical genic headache. Cervical neck genesis, like Genesis in the Bible, the beginning, cervical genic. It comes from the back, and if it's the back to the front, that is the easiest headache to solve. Even if it's a migraine. I've had patients with migraines once or twice a week. They're back to the front. We worked on them 3 times. It's been a year. They have never had a migraine again, right? They are easy to solve because it's a dural issue, it's a tension issue, and it's a vascular issue. So you resolve those and they won't have headaches anymore. Okay, so you're indicated if patients complain of headaches, if there's a trauma, cranial trauma, mini strokes, vascular problems, we're going to test those out. If they have tumors, you want to do this. This is going to relieve pressure around the tumor. You're not going to get rid of their tumor, but you are going to relieve pressure around it and give them relief, right? If they have double vision or eye tracking issues, this is indicated. But now look, if any patient has double vision, that could be a very serious, life-threatening issue. So you must tell them you have to go to see a medical doctor before. Right? You're not going to hurt them with this treatment, but you may not help them, and you're going to prolong care. And so you need to get them to an MD. So get them into the MD, get them the evals. They're going to need brain scans. And if all that's okay, have them wrap back and work on them. Okay, vertigo, ear issues, tinnitus. Now, tinnitus, you got a 50-50 chance of fixing this with manual therapy. Tinnitus could very well be a heavy metal exposure. That's that they had, like if they're a chemical worker, if they are lead, mercury, these heavy metals, it'll cause tinnitus. Could be a liver problem. There's a whole lot that can be related to tinnitus, but sometimes you can just open up the system and it goes away. Okay, vertigo. I've had pretty good luck with vertigo, but everything you're going to do is going to start with the venous sinus drainage, and that's the first class. Okay, high pressure diseases. This is high brain pressure diseases like multiple sclerosis, epilepsy, some autism is this. And so the brain is extremely sensitive to barometric pressure, right? And so if there's too much pressure in the head, you want to get that pressure out. That's why you're going to drain the veins to do that. Okay, you're not going to cure a disease, but you can sure help people. Trigeminal neuralgia or any head-face sensitivity issues. Okay, you got to get them to an MD first. You got to rule out tumors and this kind of stuff. And then if that's all clear, then you can work on the trigeminal neuralgia. Now, trigeminal neuralgia is a much more complex issue. You've got to look at it from all different angles, and it's more complex. So if you have somebody with trigeminal neuralgia and you're not sure, just pass them on to somebody who knows more than you do. I've had really good luck with trigeminal neuralgia, very good luck. But it takes a lot. It takes the whole system to get it to go away. But most people they're out of pain, and some stay on medication and some get off the medication. Okay, so if there's dental surgeries, braces, or implants, anytime they're changing the shape of their face, right, you're going to have to adjust the fascia. If you adjust the fascia, as they're moving the bones, they're going to have a much more pleasant experience with these implants, braces, and dental surgeries. And it's not just the face. If they're doing implants, they may have pain down in their neck and their chest, right? Because that's all connected, right? Okay, contraindications. So double vision, that's a contraindication. They have to see the MD first, and then you can work on them. Here's something. A headache that occurs in the night, or the patient just wakes up with a headache with no trigger. This could be indicated, this could be an indication of a tumor or something bigger going on. Like if there's no trigger and they just wake up at night with a headache, have them go see a doctor first before you start working on them. Okay, any sensitivity loss in the face, lack of movement or reflex on one side of the face, that stroke where one side drops, that's a medical doctor visit. Anything with a symptom pattern that you don't understand. If everything they're saying just doesn't line up, nothing makes any sense, have them go see an MD and get some scans and get some images first. Okay. And also, we should say that you know your limits as a manual therapist and try to stay within your limits. Now, our goal is to increase your limits and bring you up. And as you get better, you're going to see more and more and more difficult patients. I see the most complicated patients imaginable. They've been everywhere. They've seen 5, 6 doctors. They've been to the Mayo Clinic. They've been everywhere. And nobody's helped them, and they land on my table, right? The better you get, the more complex your patients will be. And so don't be afraid to tackle the hard people. But if you're striking out or you're finding that they're getting worse after your treatments, you gotta know when to pull the plug, okay? And get them to somebody else who's maybe more experienced than you are, right? Just know your limits, please, because as we go into these more advanced manual therapy techniques, you can hurt somebody with these techniques. You can. And so our goal is to give you this powerful work and have you express it in a very safe way, because the more powerful the work is, the better your results. And the easier it is on your hands, too. I mean, and that's something. Here's the expected outcomes. Better circulation. The veins and arteries are open and they're soft. That's good. Balance the pressure within their head. And so the blood getting out and the blood going in. There's no restriction anywhere, so the fluid is just moving. Okay, that's good. Neuroendocrine system is better. So if things are open and there's more blood, there's more oxygen, there's more glucose, your neurons can connect. You're going to balance the body. The visceral activity is going to be better because the brain is able to communicate better. There's not a locking down. You're going to bring the body into more of a homeostasis and function. The HPA axis starts in the brain. It's going to work better, right? Your HPA axis is like that hormonal cascade begins there. Okay, your electrical activity is improved. That's your ability to think. You're going to have less brain fog. Motility of the head and brain is improved. Okay, so motility. So what does that mean? Okay, motility. So I have this pad, right? Mobility is its ability to move around. Motility is its ability to move among itself. So your liver, say, all your organs, everything, actually your brain, has a motility. It moves among itself. There's a movement that it makes among itself. And the liver is up next to the stomach, and they move in relationship to each other. That's mobility. Okay, we're talking about really both. The fascial restrictions are going to restrict both, and they're both very, very important. Okay, emotional regulation can be improved. Well, if your brain works better, that's obvious. Okay, a true cranial series is going to involve all 7 physical medicine systems. And I'm going to go into why. I'm going to go into why here. And this is a very fundamental class. We're not going to go over each kind of headache. And I'm not going to go over the intricate details of the skull. I'm not going to do that here. We can do that later. I want to give you the broad overview here, because that's what's actually going to make you more effective quicker, right? That's my goal, is we're going to get this medicine out there and help people. We're going to help you fill your practice, and we're going to help your patients get better. Okay, so why does your intracranial pressures matter? Okay, the brain is not homogeneous. It's not one single brick of stuff. It's a whole bunch of different stuff in a pudding, basically. If you see the brain in an unpreserved cadaver and you cut the membrane, the dura off, it just pours out like a pudding, right? But inside that pudding structure, and honestly, nobody knows how it works, okay? Inside that pudding is arteries, veins, and lymphatic vessels. Yes, there's lymphatic vessels in the brain. Okay, different densities throughout. If you had a cranial injury where you got bashed in the head like this, you can have strains through your brain, which can be seen on a CT scan. Okay, components of the brains are different shapes and densities. The brain within the skull cannot be palpated, but the activity can be felt. Okay, the brain produces an amp of electricity to function. Okay, and when I say an amp of electricity is movement of an electron. Anytime an electron moves from one point to another, that's measured in amperage. That's not voltage, that's amperage, right? And anytime an electron moves, anytime electricity moves, there's a magnetic field associated with that electron moving, which creates a field around that. And so that's your electromagnetic field on an electromagnetic spectrum. And so anytime there's electricity moving, so I'm thinking in that part of my brain, you can feel the head and you can find exactly what part of my brain is functioning by being sensitive to the magnetic field. Now, if you're a body worker, you're pretty aware of this, and let's bring that down to a very logical and not a woo-woo place. Let's bring it into like how the body actually works place, right? It's coming out of the body. It's a real feeling. It's a magnetic field, and you can trace it to an actual structure. Now, you can train yourself, like when you use your vacuum cleaner and you touch the cord of the vacuum cleaner, you can feel that buzzing, right? And you can put your hand on the refrigerator and feel that buzzing, right? That's electromagnetic field you're feeling, right? And if once you get your hands dialed in, and it doesn't take much, you can feel that in the brain, because the brain is very electric. It's very electric, right? And so you can feel this stuff. Okay, the whole point is to reduce fluid buildup and allow for the joining of the nerve fibers, motility of the brain to move, and glide of all structures within. So our testing is going to look for, are the structures stuck or impinged somewhere, and releasing those structures and creating glide. It's all about glide. It's getting anything that's stuck anywhere to move again. And if you can create that, that's real therapy. That's real help. If you look at a three-year-old child, they're gliding everywhere. They don't have any pain. They're moving great. But as you age, things start sticking. As you're at the computer for hours, things start sticking together. You lose glide. And so really what we're doing is creating glide, right? And that's through fluid dynamics. Okay, it can all be done externally, and I'm going to show you improve that. Okay, let's get into it. So vascularization of the brain. The brain has no glucose or oxygen storage capacity. If blood stops, you die, period. Okay, the intervertebral artery feeds 25% of the brain with blood supply. The jugular vein is 90% of the brain's ability to dump blood. If that jugular is stuck, that's 90%. You squeeze that down and you make that to 70%. Now you're going to have a buildup of blood in your brain. You're going to have an overpressure and you're going to have pain in the dura. Okay, this is a picture of the circle of Willis here. As you can't see, I'll move this over. So that's the circle of Willis. So this is the arterial system coming up, and it's like this roundabout inside the brain where all the blood is delivered. Well, we're going to be working on that. Like, just because it's in the brain doesn't mean you can't work on that. We can. So these vertebral arteries join internal carotid artery at the circle of Willis. So the internal carotid can be accessed here, and it's a great testing point. You pull that and you can test all through the brain with that. Now I'm going to show you the logic on how to test and treat veins, nerves, and arteries. You remember how I said that muscles guard irritations on veins, nerves, and arteries? You can test very exactly and treat exactly where the dysfunction is. Okay, so say I want to test this artery. Okay, I want to test that artery. So you've got the internal carotid coming up and the external here. So I want to test this piece of that artery. If I take this artery and I pull it down, and I pull it this way. So I'm taking this artery, and you have to know where this stuff is. I take this artery and I pull it down. If I pull it down, I'm putting pressure on this section, pulling that down. If there's a restriction, say there's a restriction here, and this could be in the brain or out of the brain, it doesn't matter. Say that's restricted. If I pull this way down, what's going to happen is I'm going to increase the tension on this restriction. And if I increase the tension on this restriction, what's going to happen is the body is probably already locked up a little bit, but it's going to really lock up. So you pull it down, you passively rotate your patient's head. If you cannot rotate their head while you pull that down, I mean, the harder you push, the more they resist that. That's a positive test, which means this artery is restricted somewhere. As I'm pulling it down, putting the restriction here, somewhere up here. Now, if I take it and I switch that, now I'm going to pull this the other way. I'll say that's negative. Say like, oh, that's not it. But the guy, he still has neck pain. He can't rotate. And most of these rotational problems are arterial or venous, right? There's some kind of vascular problem if somebody can't rotate their head. I go there first always now. I don't just work on the C-spine. I go straight to the arteries first. That gives me the best results, because if they can't rotate their head, something is restricted, probably an artery or a vein, because there's a lot going on right here, right? Or it could be the brachial plexus, but rotational restrictions, it's almost always an artery. Okay, so now I want to test this bottom part. So I want to test this part. I want to say, okay, so this up here, negative. That was a negative test. So that's no problem. So, okay, but I suspect there's a problem here. So I'm going to take it and I'm going to lift it up through the thoracic gland. I'm going to lift it up. So I take this and I lift this up this way. And so that's going to pull from the heart up. And if that locks their neck up, then I know definitively, no guessing, I know if I pull that up and they can't rotate their head passively, you try to turn their head, then there's a restriction between where my finger is and the heart. And you have to go there and work on that. Okay. And that test, that logic goes through the entire body. Every nerve, every vein, and every artery can be tested the same way. And once you figure out how to roll through these, you're going to be slicing right through everybody's problem. You're going to find exactly what their problem is. You're going to fix it, and they're not going to need 72 visits to fix their neck. And you may be like some people rubbing things and just getting lucky, right? But we're going to try to get rid of that and actually be very, very specific. Find the problem, fix the problem in a permanent way. And when you do that, that person who just got fixed up from you is going to go tell everybody, and you're going to fill up through all their friends and family. Our clinic, we see 500 a month. It's all friends and family referrals, all word of mouth, all word of mouth. And so we don't need to keep the same people coming back and back again. There's always people in pain. And so we're always starting over. We fix most people in 2. We have them come in for 3 to make sure. So we're a 3 visits clinic. Okay, so that's how that works. I hope that logic. Now look, now say we have that circle of Willis going up, and say I have pressure behind my eye, and I have like this headache here, and I suspect ophthalmic artery, or one of the venous processes here. But ophthalmic artery, if you can treat the arteries, you're going to treat the veins because they're right next to each other. Arteries are way easier to feel. Okay, and so I want to test that. So what's the logic of testing the ophthalmic artery? Okay, that's the artery behind your eye. So let me give it to you. Hopefully you came up with it. You take the eye, you move it forward, and I'm putting tension pressure this way. And that's going to pull the eye out just a little bit. It doesn't hurt, it's no problem. But that's putting a tension on the ophthalmic artery, which goes to the circle of Willis, which goes to the internal carotid. So if I pull that, and that person cannot rotate their head, that's positive for the ophthalmic artery, right? And you're saying, well, how the hell do you get to that? It's behind your eye and your cranium. So you can. You can very well. And I'll just draw this out for you. Okay, so now, you've got a train car. So I lost my pin. Okay, so I've got one train. This is like choo-choo train. It's connected to another train car, and that's connected to another train car. These 2 train cars are in a tunnel. That's inside your head. This is the circle of Willis. This is the ophthalmic, very far away. This is the carotid, the internal carotid artery. I can reach this train car because it's outside. I can't really get to this train car. But what I can do, if I pull this one, guess what happens? It creates an elongation because it pulls this, it pulls that, and the entire structure gets pulled. As long as you know where things go, as long as you know your anatomy, there is nothing you can't get to. Now, for this particular technique, you can go try it. So you pull the internal carotid. You're going to have to just find it. You're going to have to know where this stuff is. It has a pulse. I like to find the bifurcation and then go back. So and it's right there. And so you pull that down. If you have a tension through your brain, you will feel that eventually here if you have body awareness. And if you're a manual therapist, you do. And so what you can do is take the eye, move the eye this way. Pull the carotid this way. Pull the eye this way. Pull the carotid this way. And you are flossing. You are taking this train car and moving it back and forth, back and forth, back and forth. And eventually you're going to create glide. The fluids around these structures are going to get more gel-like and slippery, and they're going to start sliding. And this pain behind the eye can very well much go away. Now, behind the eyes, there's also a cavernous sinus, and there's a couple techniques to drain that, which maybe we can show that in a live class because it's pretty complicated to get to. But everything can be got to. And so if you understand the principles of which I'm showing you, and you know anatomy, and you get the concept of this test, you can apply this to anywhere in the body and just go for it. Okay, let's go to the next one. Now, Now here is where does this vascularization of your head come from? Okay, and I'm going to go over the skull in a second. But where does this come from? Well, it goes to the heart. And so as I'm lifting carotid out or jugular out, I could be lifting it all the way to the heart, okay, the jugular to the right atrium. Okay. And so how do you test the vascularization below the clavicle underneath the rib cage? Now, I for years trying to figure out how to get inside here, and we've done it, right? Um, and I'm going to give it away here. Okay, so I'm going to annotate again on here. Okay, and so if you take your hands and you push down on their chest, on the sternum, on the heart side. So I'm pushing on the heart. That's right atrium on this side. So pushing down on the heart, it's more central and it's bigger than you think, right? Push it down, and you now I'm locking on the heart, and you go towards the feet, towards the head. Okay, so you go towards the feet, towards the head, superior, inferior, and you feel where is it restricted. You push the heart down, and can they rotate their head? While you hold that, you try to passively rotate their head. If it completely locks up, there's a problem there, and it could be a vagus problem. So if the vascular stuff doesn't work, there's an emotional vagus problem, and the brain's telling that to guard. Okay, so that's our vagus treatment. We figured out how to release that. But what we're doing here is thinking, okay, we're checking the heart for the vascularization of the brain and below the diaphragm. So where do you go? Okay, so let's annotate on this. Okay, so I'm going to take the heart and I lift it up, pushing it up, and it feels restricted going up. So what is the problem? The problem is the diaphragmatic connection to the heart, the vascularization as it goes through the diaphragm, the vena cava as it comes out of the heart into the liver. And so you can steer it and feel exactly where the restriction is, and you know where to go. Now, if it's restricted going down, then so if I pull it downward and there's a restriction this way, then it's stuck somewhere probably in the thoracic inlet or the thoracic outlet, whatever you want to call it. It's the same place. Okay, right here. Okay, it's probably stuck there, right? And you want to work where you're indicated to go, and then you go recheck. You always recheck so you know you got it. And so this is the heart ascended? Is it too high? Or is it descended? Is it too low? Now look at this vascularization. This vascularization comes up the neck, and then there's vascularization that goes, the cervical, the brachial branch comes right through here. And so you hold the heart down and you move their arm. If you let go of their heart and their arm can move a heck of a lot more, then that's impeded vascularization to their arm. And you need to work that. And that's where you go. And we've got great techniques for this. But if you put your mind to it and you don't go to the class, you're not available to go to, you can't make it, then I bet you can figure this out. We were able to figure this out. And I bet you can too. But I'm giving you a boost towards it. But try to make the class if you can. Okay, so now we're going to look at the venous system of the brain. Now, this is what we're going to do in the intro class. Now, so we're talking about a headache is probably an overpressure problem, unless there's damage, but there's really always an overpressure issue. If I hit my head, the skull locks down. And so the periosteum, the membrane around the skull, is the periosteum. Now, if I hit that and I cause damage, it's going to guard, right? And the periosteum, that membrane is very innervated with nerves. There's a lot of nerves on the periosteum. Now, if that's locked down and those nerves are irritated and it's guarded, anything pulling on that is not going to happen. So say my periosteum here is damaged, or where my bicep attached in my shoulder here, like the periosteum's damaged and it goes into the attachment and through the bone, right? And so my bicep will be chronically tight and I won't be able to fully function that bicep because if I flex my arm, it pulls on the periosteum where it finally goes into the bone, right? Say the short head right here. Okay. And so unless you release the membrane around the bone, you'll always have a muscle guarding and an inability to fully use that muscle, because that's where it's attaching and it's going to guard that. And so it will always be a little locked down. We did this experiment at the clinic. We had like 10 of us, and we worked the periosteum around our legs. We just did the legs and the hips and the pelvis, and everybody in the room could do a full flat-footed squat. And only one person could do that before we started, right? And so the periosteum is very, very important. Okay, so venous sinuses. And so if you can see this, so inside this skull, you see the black marks where I marked it black, right? There are caverns, little grooves in the skull. So when you were a baby, there was veins there, and the skull was soft, and the skull got harder over time, and the veins still sit in the same location. And so now there's a groove in a hard shell. But can you get to that? How in the world can I get these veins to drain, right? These are the venous sinuses. And then we're going to drain the straight sinus, the transverse sinus, and the jugular. It's a big one, is the jugular. And that's going to relieve pressure through the entire dura. Now, if you have a headache, you have a headache in the dura. The dura is what feels pain. You don't feel pain in your brain, you feel pain in the membrane. Okay, so that's an important thing to remember. Okay, and so what we're going to do is work through the dura. We're going to work through the membrane, through the periosteum of the skull. Now, how do you release the inside? Is these sutures, the membrane on the outside is directly connected through the sutures and these emissary vessels to the inside. It's the same tissue, right? This is the same tissue. You got to get a scalpel to cut this stuff apart, right? There's nothing like free in the body. There's no empty space. Everything's connecting. There's liquid and glide of tissues, though, right? And so by releasing the sutures here, you can release tension here and get the inside of these grooves and then start draining and getting the blood to come out. But first thing we got to do is we got to do the jugular foramen, which is in here. I can put the pin in there. It's right there, right? Brown bone and orange bones. It's right in between those two, right? We're going to drain that, and we're going to open up areas around the foramen magnum. But what goes through the jugular foramen? The jugular vein, so that's 90% of your blood, the accessory nerve, which goes to here and causes that trigger point, and the vagus nerve. So what could possibly go wrong if there's a problem in that hole? A lot, right? And so we're going to start with that. We're going to fascially open this using the diaphragm and the connections that we saw. So, the jugular goes to the heart goes to the diaphragm. And so if we can get them diaphragmatically breathing while we do this technique, it's going to work even better. So we're going to fascially open this hole. They're going to do diaphragmatic breathing. We're going to coach that, and it's going to pull these structures out and in and out and in and out and in while we lean on their head and fascially open this thing up. While they're breathing, that's going to create the flossing, and it's going to open that up. And then we're going to stretch the entire system of these three structures all the way to the right atrium of the heart and open the entire thing up. And that's going to get the blood flow get the blood flow out of their head, right? And that's going to relieve them of their overpressure, this entire sequence, right? It's a very intelligent sequence. We're going to open the thoracic inlet, do the jugular, work these guys, split these veins and arteries all apart because they can be glued together, and then go to the inside of the cranium, get that. And then we're going to open up the veins all through this cavity and through the brain itself. And then we're going to test anything we find and give you a theory on how to fix it, because there's no way we can teach it all. There's no way we can teach it all. But you need to get the theory, and then you start looking up the anatomy, and you can piece this together. The power is in the theory, not the techniques we're going to hand you, right? Okay, so there's more on this on our website, on our headache talk. There I do a little headache talk, but that's pretty good. I don't want to do too much details in this, because we're gonna lose the forest for the sake of the trees. Now, here's something that we drew up, right? These are all the muscle connections to the bottom of your skull. This pink and this red, they're the same. We just used a different color. That was our mistake. But every one of these is a muscle connection to the skull. right? And so what could go wrong if there's an asymmetry to your neck muscles? Everything is going to be rotated and pulled and twisted. Your sphenoid is going to be off. What's sitting on the bottom of your sphenoid in the Turkish saddle right there? You know, you got your pituitary hanging there. That's important. What's right behind your eyes right there? The sphenoid is exactly right behind your eyes, sitting here. So the muscle balance of all of this, the oral fascia, the musculature, all the connections to the bottom of your skull, the base, is vital. And to release that, truly release that, there's a couple things you can do, and we're going to talk about that. And one of them is rehab the breathing pattern disorder. That's going to relieve tons of pressure here, but also you got to let some stress go in your life. You got to have some joy in your life. You got to feel good about what you did during that day that you spent the day, because as the more and more disappointed you are, the more tension there will be on this, right? And so you got to find a way to have joy in your life. Okay, so the myodural bridge, I hope you've heard of this. If you have not heard of this, this is the best video that I've ever seen on it. I don't have permission from them to play it. Not that they said no, they just never got back to me. So if you type this Do 16 myodural bridge into YouTube and watch that, and the good part, it's pretty gross video. So it's a raw cadaver, and they kind of chewed it up a little bit. It's not pretty. But at 255, if you go there, that's the best demonstration of the myodural bridge I've ever seen. And what the myodural bridge is, it's the muscle connections of the suboccipitals straight to the dura. Where's your headache? It's in the dura. Always in the dura. Okay? So go watch that and then come back. Okay, so here is my drawing of that. So you've got the suboccipital muscles connected to the dura through the foramen magnum. You can't really tell because the picture, but it's hard to draw. Going up through here, and the dura, this membrane encapsulating over the brain, going all the way to the front. Okay, and that's your tentorium and your fox running through there. Okay, and so that's going through the brain. This is a picture of it outside the brain. And so here's your muscles. There's obliquus capitis, rectus capitis posterior major, rectus capitis posterior minor. So that's RCP min for short. We'll never say rectus capitis posterior minor. You say RCP min. Okay, so RCP min is the muscle that's the most directly connected to the dura. This is demonstrating the dura, and that's the most, because that's the same vector. So when I'm talking about a vector, it's a line of force. It's a tension, a pull of energy, a movement, or a tension in a specific direction. And the RCP min has that, right? And you can palpate that right here because it goes to the occiput, it goes to the dura, and all of these go to C1 and C2. And so if C1 and C2 is out, right, and it's like there's C1 and C2 is out, are we looking at venous sinus drainage? Are we looking at dural problems? Now we're looking at all those fascial connections underneath before you try to push C1, C2 back into place, because that's not going to stay, because C1, C2 is a bone, and bones don't move on their own. They are pulled by wires that are connected to them, okay? And so the myodural bridge is incredibly important, because what goes down your back, don't want to go there yet. So what goes down your back from RCP min, that whole, remember that from anatomy trains, the back line, it goes down the paraspinals all the way down your back to your feet. All of that is directly connected to your brain, right? And it's directly connected to where a headache lands. Now, if you have a patient, now here's like a pro tip. If you have a patient with headaches and sciatica on one side or both sides, headache, sciatica, it's probably the dura. This is a dura problem. So you need to work the dura, and both of those will clear, right? So headache, sciatica, go work the dura. If you don't know how, look it up or email me or something. Figure it out. We'll figure it out. Okay, so fibromyalgia and whiplash connection to the cranium. This is a giant big deal. So if you're asleep, please wake up for this. Okay, so this is a study done in 1997. Let me move me out of the way. So They took 100 patients with a traumatic neck injury, and they took 60 patients with leg trauma, and they are all evaluated for pain 12 months past the injury, right? So past 12 months past their trauma, their car accident, or whatever it was. Okay. Fibromyalgia was present in the neck group was 13 times higher than the leg group. Okay. 21% of the neck group developed fibro within 3.2 months of the injury. This is like 90 days after their whiplash. Now they're getting fibromyalgia. Okay. 1.7% of the leg fracture group developed fibromyalgia, but that's not different than the normal population rate. Okay. So fibromyalgia was developed in people with whiplash. So whiplash is an injury to the RCP men, but it's an injury to the dura. Fibromyalgia is a dural injury, right? And it's a sympathetic nervous system injury, right? And so I'm going to go into this deep detail. So what this guy's Vernon in 2001, he speculates, okay, so fatty degeneration of RCP men following the trauma removes proprioceptive signals, thus opening the pain gate that normally blocks nociceptor transmission to higher centers. And so what he's speculating here is RCP men atrophies, gets fatty, and it's a huge proprioceptive muscle. So when you move your head, so proprioception is where you are in space. That's how your body knows where it is at all times. My head's like this. I know my head's like this. In the dark, underwater, in zero gravity, whatever, you're going to know the position of your head based on probably the RCP men giving that information over. That's proprioceptive, right? And it's from the bottom of your feet are proprioceptive. And so as RCP men degenerates, you see this on old people, right? With that head forward, RCP men's kind of down on them. They lose their balance. And so the signals drop, pain gate goes up, and so their pain signals become, because pain happens in the brain starts interpreting pain differently, usually higher. Usually it doesn't like the signal more. And so more pain. Okay. Okay. Boom. Okay. So this is a MSK. This is an MSK thing that just from our experience. Fibromyalgia may be a sympathetic dominant issue sourced from the sympathetic trunk. Now, I've got a drawing here of the sympathetic trunk. Now, you're looking at these ganglia. These ganglia all the way through here, that's your sympathetic trunk. Now, the ganglia, honestly, the nervous system's a mystery. And people who think they know about it don't, the more you learn about the nervous system, the more you know that you don't know. And so if you've got an honest scientist, he'll tell you that they don't know. And I'm going to tell you, I don't have a clue. But what I do know is what works in clinic. And that's what I'm telling you. Okay, so these ganglia, I would think of as roundabouts of information, right? The information is kind of getting processed there before it goes up to the brain or somewhere else. Okay, that's the sympathetic trunk. Now, if you've damaged that, the dura, because look how close these ganglia are to the rib heads. So they're right at the rib heads. And so they're very close to the spine. They're very close to the spinal cord and the dura matter that's around that, right? So now you got a whiplash and boom, it got yanked and pulled, and these things got pulled in with it because it's connected. And now you've done some damage to the sympathetic trunk. I have never tested a fibromyalgia patient for sympathetic dominance that wasn't positive. And what sympathetic dominance means is their pain signals are switched. And so if I have somebody with fibromyalgia and I just brush their arm like that, that could be extremely painful for them. That's a signal from your arm. Your brain interprets the pain. It goes through this little wiring, and then it sees it as painful, but that shouldn't hurt. What also happens, things that should hurt a lot don't hurt at all. And so literally the pain signals are flipped and turned upside down. And it's not good. It's not good. And we have a treatment to get you out of that. But here's the test for it. Okay. So you lay the patient down. I'll annotate to make this useful. So what I want to do is I want to put a tension I want to put a tension, say, on the ganglia through the dura. Okay, so how can I do that? It's all one piece, right? So I'm hoping you guys know this. The brain, the nervous system's all one piece. As it comes out, and the nerves are all connected, right? If I lift my leg up and I do a straight leg test, so say you have your patient laying on the table here. Reannotate. Okay, so here's the patient laying here. There's their head here, okay? And you take their leg and you do a straight leg test, and I raise the leg up. What am I doing? So now this is their foot. So I raise the leg and you do a little internal rotation of the ankle to really stretch the sciatic branch. So I'm stretching the sciatic nerve. If I stretch the sciatic nerve, I'm pulling the dura this way, pulling it down this way. I'm putting tension on the brain this way, right? And so I asked them, okay, so you do that, you say, where do you feel it? If it's behind the knee, you know it's the sciatic nerve. And if they say it's just a stretch, well, that's still a sciatic nerve. Okay. And so you hold that. You don't move that leg. They're at their max stretch, but you're not jamming on it. It's just when they can feel it. Then you passively take the head, passively, you raise the head up, chin to chest, straight like that. And what is that going to do? That's going to take the brain this way, take the dura that way. And so now I've taken the whole system and I've done this. Now, if they're sympathetic dominant, what's going to happen is then you ask them, is the pain better, worse, or the same in the leg? If they're sympathetic dominant, they're going to tell you, oh, it's much better. It's gone, right? But that should hurt more, right? If they have sciatica, it'll be worse. If it's the same, that's a normal person. That's what we hope for, the same. If it's more, it's sciatica. That's a basic sciatica test. It's a different version of the slump test. You can look that up. But if it's better, their brain has flipped pain signals. They're upside down on pain signals. And then so now you've got to say, okay, you're sympathetic dominant. That's your fibromyalgia, right? I think just based on our clinical results with this, it's really easy to turn back over though, because you can retest and it'll be better. And so you test them, you fix it, and then you retest. You test it, you fix it, you retest. If it didn't work, you try to fix it again, you retest. If that didn't work, you do something different, then you retest. But you don't stop until you retest and it's gone, right? Don't be afraid to retest, right? Because that's how you know you got it. And that's how the patients know you got it, because they're in that body. Okay. And so that's sympathetic dominance. Okay. And so how do you fix sympathetic dominance? We use the vagus treatment mostly because this is a brain problem, I think, right? So the vagus treatment knocks this out pretty quick, but you don't know that. And so let's give you this one. And so all you've got to do, and we have a process for this, and you can email me if you really want to know. You have to put those ganglia in a position of ease. So you work the ribs by taking the ribs and moving them in and rotating them. You're using position of ease by working each rib individually and moving these ribs this way. Why is this not going? Okay. By moving the ribs towards here, position of easing the ribs. So at the rib head, loosening up. So position of ease is going to the place that it's the loosest. And you hold it there for a while. So you position of ease the ribs and you rotate them up. And that'll position of ease the ganglia and hopefully let that go. We have a pretty detailed process on how to do this. But if somebody's sympathetic dominant, man, they're in it until you do this, right? It'll last for years and years and years. You may be able to fix it by rehabbing the breathing pattern disorder to get those ribs moving. That may work. Every fibro patient has a breathing pattern disorder, period. They all do. So maybe you can do that. And I want you to start thinking about this, but we can show you how to do this. You can come to the clinic, shadow, do whatever you want. I want you to be a good practitioner. I want to get this medicine out there. So I'm not keeping any secrets. They're 50 and they're suffering from whiplash damage, and they've been suffering it all their life since they were 16. Okay, so what happens is you get the whiplash, you bang, bang. right? It's a bang bang. It's a dural injury. Their dura is injured. Okay. RCP min is directly connected to the dura. Remember that? Or through the myodural bridge. It's atrophied. So you can go and you can feel and palpate RCP min and get your anatomy books out and find these guys. And so you can feel RCP min. And if it's just like a hole there, they've got whiplash damage, right? And RCP min atrophied, it just faded away. It becomes fatty. Okay. Proprioception goes down. Their balance isn't so good. And their pain perception increases. You see how it's all connected. Fibromyalgia, whiplash, and sympathetic dominance. It's a triad. It's a triad. So what we get these patients with terrible whiplash, we treat it right away. And you can see that kind of fibromyalgia symptoms coming on, where they just have pain in this spot, pain in that spot, weird stuff going on. They're like, well, I put my shirt on, it hurts. And they don't have a diagnosis yet. And we don't diagnose them. It's not in my scope. And I don't actually care about your diagnosis. I just want to fix your problem, right? We want to actually back it out. And you can do it without the diagnosis. That's better because they won't be playing head games with themselves, right? So fibromyalgia is a syndrome. Anytime you hear the word syndrome, that means the doctors don't know. It's a guess. It's like idiopathic. It's a fancy way of saying, I don't know, right? It's idiopathic. I don't know, right? And so so here we go. So here's the whiplash pain patterns. This is really important. And I think I got this out of Leon Scheitau. I adapted this chart because theirs was more than I wanted to go into. So I just made my own. I wanted it to be very just for whiplash patients. And so this is a pain pattern post-whiplash years later. It doesn't matter. It's years later, or it could be immediately. Okay, so we at C3, so C3, so this is a dermatome, C5, C6, C3. Now, when you see this on a dermatome, that's related to the nerve root. So if it's C6, that's related. So that would tell you there's a problem where C6 is at the root where it comes out of the spine. That's C6, right? So there's a problem at the nerve root or somewhere in C6, okay? And so you've chased that nerve down. That's the law of Hilton, right? They're going to have pain on the skin, but what's underneath? The same nerve. So you trace the nerve, right? That's why the law of Hilton is so important to understand. It'll tell you where the problem is. Okay, so but at C3, pain is reported to be very high. It doesn't matter how long later. Think whiplash and think cranium and think dura. Okay, at C5 here in the shoulder, there's some pain, and in here there's slight pain. Lots of pressure and pain at T5 right here, which is really up here. Sorry about that. That needs to be moved up. And then severe aching at the TL junction, thoracolumbar junction. Burning of hands and feet. That is a telltale sign that it could be a whiplash or a dura problem. Is this whole hand burning and whole feet problem? Or somebody has a stocking glove syndrome where it's like, I'm just numb. The whole hand. There's not one dermatome. You got to think dura. Think about the dura, okay, and the feet. So if you see patients and they're having this, we had a patient just last week, terrible car accident. Every single one of these was positive. And she's going into fibromyalgia. And so we start with the vagus treatment. Our clinic with somebody like that, we start with the vagus treatment. We get the trauma out first. Okay. And so what does this treat? What does this mimic? So carpal tunnel syndrome. Look, C6, carpal tunnel syndrome. They've already been to the hand doctor and it's like, well, there's nothing wrong, right? Or thoracic outlet syndrome. It's stuck up here. That's going to give you the same. And they've been to the doctor and there's nothing wrong, right? And so these are all common. These pain spots are all common to fibromyalgia patients. So to diagnose fibromyalgia, don't quote me on this, but I think there's 15 points in the body along the spine and the back. And the doctor pokes on these 15 points. And if you have pain in 11, you have fibromyalgia. That's how they come up with that. It's like, as a manual therapist who does very detailed testing, that's ridiculous because I'm going to find that on a lot of people, right? And so I want to just fix them, not diagnose them. That's not even in our scope. It's very important you're not diagnosing people. Okay, so desk posture, micro traumas, and this is where the exercises come in. And Dr. Emily Blair from Blue Sky Chiropractic is going to be helping with this class, and she's like a voted best chiropractor in Albuquerque. She's had more training than anybody, I don't know, on the planet. She's so qualified to teach this. So she's the most qualified person that I know. And I'm really happy to be co-teaching this class with her because I'm going to learn a lot. Okay, so desk posture, micro traumas, and dural tensions. Okay, so look at this person. This is everybody in the modern world who's tied to a chair, right? And this is 80% of my practice. Well, it used to be. Now I'm getting hard neurological people, but they're coming to the clinic with our interns and stuff. We give them these people. Okay, so I'm gonna annotate on this. So if you look at this, right here at this T1, where T1, C7 meet, there's a hinging there. There's probably 42 pounds of pressure because you take the weight of the head, 12 pounds, and you multiply it from the distance, the fulcrum, the distance away from the fulcrum point, right? And here you're going to get 42 pounds or 60 pounds if you're looking at your phone. If you're looking down at your phone like these teenagers are doing, that's like going to be 60 pounds, right? And so no kidding, you have neck and shoulder pain. Yeah, right? But what's that going to do? It's going to put a chronic pull tension on this. And where is the RCP man sitting right here? It's connected into the back line all the way down here. And that 42 pounds is transferred straight into your brain and ends at your eyes. This is the back to front headache. This is so easy to treat, right? And you probably can fix it right now just by rubbing their neck, but it doesn't go away. There's always a vascular component because if I keep my head down like this, eventually these guys are going to get stuck. And I'm never going to be able to raise it without choking off the blood vessels, right? If somebody's got internally rotated shoulders, so what you're going to have this is the perfect desk posture. So shoulders are internally rotated, head's forward posture, diaphragm can't go down because the diaphragm sitting, let me clear this out and I'll show you. So here's your diaphragm sitting at this angle. That's the diaphragm. Now, the diaphragm goes like this, down, and it's a piston. So your body's a piston, right? So you've got your trunk right here. You've got the diaphragm on top, you've got your pelvic floor on the bottom, and you've got on top is your oral fascial diaphragm. All three of those need to be aligned and moving. They move together. So when I breathe in, my diaphragm goes down, but my pelvic floor goes down, and they move like this, those two. And the oral fascial diaphragm sitting here follows that. That's why this is in the headache class. And so this happens. And when I stabilize, the diaphragm comes down and this comes up. So the pelvic floor locks closed while this comes down. If that doesn't happen, urine happens, leaking happens, right? And so that's your postpartum treatment. And so we have Aaron Hemphill and Kalina Chan teaching a postpartum class, diastasis and this kind of stuff. And I'm telling you, what they do works in the clinic. What they do, the mama rehab is like Erin is like a ninja. She works here. I don't really know what's going on, but she's going to teach you how to fix these people, and what she's doing works. So, but I let the moms, because it's pelvic floor. So we let women treat women. I find that women are much more comfortable with a woman, especially working on their diastasis and postpartum. I just let the women take care of it. Okay, so this guy's diaphragm is this way. So where is that pressure going? This way. It's not going down into his pelvic floor. It's going against his back right here. And so what will happen is the body will start overactivating the posterior portion of the diaphragm. It's called the crural portion. This is down the back of the spine. It'll start activating that to try its best to get it to go down this way. And so then you end up with really thick paraspinals. And this is a pretty big rehab. This is an exercise rehab of the breathing pattern, of a breathing pattern disorder. So this person is going to be an upper chest breather. And I'm going into that now. So I'm going to explain what that means, what it has to do with headaches and all body-wide pain. And it wraps back to fibromyalgia. So they're a mouth breather. That's bad. They have a breathing pattern disorder, and they're going to have a headache. They're going to have a headache. But here is why the massage works for a cervicogenic headache, but it doesn't last. Okay? So your diaphragm is sitting here. Okay, that's your diaphragm. Now, if I want to get air to my lungs, the lungs here, if I want to get air in there, I have to create an expansion, right? I want to get a negative pressure in my chest cavity. This is and higher out here. So air goes to the negative. It always goes towards the negative. It's going to go down my mouth. If I could expand this cavity, that's the sucking motion of breathing, right? Now, I've got a breathing pattern disorder. My diaphragm doesn't have its full excursion. It's not doing this. Well, I'm not going to drop dead over that. I'm going to create a compensation pattern. And so that compensation pattern is I'm going to take my chest here and I'm going to expand it this way and up because I'm at my desk and this is actually open, able to move. I can't go down, but I can come up. And so you create upper chest breathing. And to upper chest breathe, you use your pec minor, you use your scalenes, SCM's involved, your serratus anterior kind of just drops out of the picture, and the shoulders drop internal, they become internally rotated, right? And so what I'm doing now, you breathe 20,000 times a day, 20,000 breaths a day to expand and lift. And so I'm lifting my rib cage via the scalenes and expanding via the pec minor. I'm lifting this and literally the weight of my chest is hanging off my neck. 20,000 breaths a day. Exercising, overusing the scalenes, overusing the SCM. I'm already in a forward posture because I'm an upper chest breather. Overusing the pec minor. 20,000 times a day. It doesn't matter how many times you rub these structures out. This never goes away, and you know that. So you have to rehab. This is an exercise fix. You have to rehab the breathing. We do manual therapy on the viscera above and below the diaphragm, and then we coach the breathing back in. But look at thoracic outlet syndrome. So thoracic outlet syndrome is an impingement on the brachial plexus, right? This is the brachial plexus circled right here. This neurovascular bundle is the brachial plexus is there. There's your artery. There's the vein. They run in a bundle like in a sheath by themselves. And the brachial plexus goes between the scalenes. It goes between the anterior and middle scalene right here. Middle scalene, the anterior scalene, right? It goes between the clavicle and the first rib. You can't see it here, but there's the first rib and the clavicle. It runs through those two, and it runs underneath the pec minor. And so you're overusing these three structures. So the clavicle and the first rib, the scalene is connected to the first rib. And so if it shortens, it's going to pull the first rib up, and that first rib comes up this way. So as the first rib rises for the scalene, because the scalene is connected to it right here, you can't see it, it's going to pinch the brachial plexus between the two bones, clavicle and first rib. Boom, it's pinched off, scalene short. Scalene is going to snip like this, the brachial plexus right here. That's going to get snipped off right there. And then the pec minor is just going to smash it. And what I found is the pec minor starts getting adhesed to the rib cage, and so does the brachial plexus and all of the vascular structures. It's all like glued down right here, and they're internally rotated. Now you can't, if you want to externally rotate these people and get their posture and get the head up and all that, you have to loosen all these structures. The brachial plexus and the vascularization are stuck in these structures. And so if I've been short like this for a long time and you bring that back without loosening and actually doing very specific work on the veins and arteries, then what's going to happen is it's coming right back, or it's not going to go at all, because because it's going to guard. You're literally creating the test. You're like putting a tension on it. It literally is going to go back. And so you've got to start thinking about testing and working exactly in the right spot. And so somebody with a breathing pattern disorder who's been sitting is going to have this thoracic outlet syndrome, and they're going to have headaches because like it's all yanking, and they're not going to have the oral fascial diaphragm function, and all this is pulling, and literally this is just hanging off their neck. Right? Where does the traps go? The traps are going to be super tight. The accessory nerve is going to be super tight. They're going to have this trigger point, and all of that's going to be pulling on the back of their head, pulling through the myodural bridge, pulling back on their eyes through their brain, pulling on the fox, and creating a pretty good headache. And that is your cervicogenic headache. And thoracic outlet syndrome masks itself as carpal tunnel syndrome because they get the C6, C7 numbness here, which goes through the carpal tunnel. Very, very rare is it actually carpal tunnel. Carpal tunnel is actually pretty big space. It's a very rare thing. So I'm going to throw this in. I know I'm talking a lot here, but you can pause it and come back, right? So if I have a nerve, so a nerve that's coming out and I'm going to get numbness and tingling in my fingers, like this is a rule, okay? So that's the thickness of the nerve, that's 100%. If I squeeze the nerve 50%, I'm not going to have any problem in my fingers. I won't even know it's being squeezed. If I squeeze it 60%, now I can't feel my fingers. If I get it backed up to 50%, that's gone. And so it's not 60% on one location. It could be 20%, 20%, 20%, and then I can't feel my fingers. Or 10%, 20%, 20%, 10%, whatever. Anytime once you get over 60 on the entire neural pathway, you can't feel your fingers. And so remember that, because you don't have to completely release this to give this person relief. You just got to get them under, you got to get it 50%. Get it 50% impinged instead of 60, and they're going to be good to go. This is why we add more treatments. So we tell people it's going to take 3, and we do that last one, even though they're better. Even though they're better, we still treat it because I know it's probably still stuck. It's just they're not having symptoms. And I want to really just nail it, right? I want to nail this, and so they don't have to come back for the same problem, okay? Okay, let me erase this and let's go. I hope this is useful. Okay, so that's breathing pattern disorders. So what happens when you're upper chest breathing? And so I told you before, say the definitive book, Breathing Pattern Disorders, is by Leon Scheitau. It's called Breathing Pattern Disorders. It also has 2 chapters in that book written by Collage, who does the DNS, the neuromuscular stability, because you can't stabilize your core if you have a breathing pattern disorder. You can't stabilize your core if you have a breathing pattern disorder. And I'll explain that in a second, very briefly. In our school, I've got 7 hours on breathing pattern disorders. Like I'm talking for 7 hours. That's the lecture portion. This is a very deep subject. Okay, so say you've got this breathing pattern disorder. Now, your upper chest breathing. Say you're a desk worker, your upper chest breathing. Overactive muscles. The SCM, anterior, middle, posterior scalenes, pec minor, that creates chronic tension on the neck of the head because you breathe 20,000 times a day. You get a cervicogenic headache, neck pain, thoracic outlet syndrome. You lose the lower rib mobility. And I'll tell you, underneath, the organs have a lack of glide, which I'll explain that. And that leads to, because now nothing can move below, and you probably didn't change your habits, that leads to upper chest breathing, and these are overloaded, and you round and round and round you go, right? And this doesn't stop unless you step in and make a change. And so manual therapy, fix it, make the diaphragm work, exercise, teach the patients how to breathe, okay? So next one. Okay, this is the anxiety cascade, Pepto-Bismol chart. Okay. You have a triggering event or trauma, that gives you anxiety. Anxiety puts you in sympathetic dominance or fight or flight. It could be temporary, okay? But you're in fight or flight. Now, when you're in fight or flight, you're using your accessory muscles to breathe, and now you start into a breathing pattern disorder if it's like a chronic anxiety, or you're like in a relationship that you just like, this person. Now you're getting a breathing pattern disorder because it's not going away. You haven't resolved the actual problem, which is your relationship, right? So it's better to be honest and live truthfully, and start eliminating things that don't give you joy. You've got to eliminate things in your life that don't give you joy. Okay. So now you're in fight or flight. Neck and shoulder pain, overuse of the accessory breathing muscles. That's the SCM trap, though, SCM scalenes, those things. These symptoms are disturbing because you have the symptoms from the last chart and you have anxiety. So what is that going to do? It's going to give you even more anxiety. And now you're going to get even more in fight or flight, more sympathetic dominance. And now your neck and shoulder is going to hurt more, and around you go. Or here you're here where your symptoms are disturbing. Oh, no, right here where you're in fight or flight. Pulse goes up, blood pressure goes up, breathing rate goes up, stress hormones released, digestion slow, you can't poop, and it doesn't go away because symptoms are disturbing and it gives you anxiety, and round and round and round you go. This is very important, and you're going to have chronic headaches, right? You know that. And so this is part of our headache treatment. You've got to fix this. Here's the chemical cascade. Your upper chest breathing for whatever reason, shallow breaths, inefficient oxygen exchange. You're not getting the expansion in your chest because your diaphragm is not fully excurging, right? And so there's a shortened transit time of the oxygen and the CO2. So the CO2 can't get off the hemoglobin. So the CO2 needs to be able to get off the blood cells, and the oxygen needs to get on. And that exchange has to happen. And that exchange takes some time, right? And it takes depth of breath to get that breath all the way into the base of the alveoli of your lung, right? And so if that's not happening, you're going to get carbon dioxide buildup in your blood because they just can't get off the bus, right? They're just going around on your hemoglobin, but they can't get off, right? There's no time. And so with the excess carbon dioxide, your blood becomes too alkaline. So now you're running like an alkalosis, right? So what happens is your body dumps its calcium, right? Because it's maintaining calcium because your blood pH needs to be around 7.3 or you're going to drop dead, and you can only go a little bit before you die. So your body's going to just dump its calcium through the kidneys, out your urine, to maintain so it doesn't go too even more alkaline because you will die, right? And so it dumps its calcium because it can't dump the carbon dioxide. Now, what does calcium do? It does a lot for you, especially in your nervous system. It makes neural transmissions very smooth and fluid. It's a great, it makes, just think about the electricity just going smooth. If you don't have that, there's bumps in the road or they can't get through, right? And so nerve and muscles are going to start functioning poorly without that calcium. You're going to get muscle cramps, tension, and nerve pain, leg pain, restless leg, right? Thoracic outlet type syndromes, headaches, head pain, behind the eye pain, trigeminal pain, right? This is coming on, right? So there's psychological and physiological effects of this, right? Because you're in the other charts still, right? So you're stressed out about it. It's giving you anxiety. Now you got restless leg syndrome. And so stress, anxiety, body pain, you're in more fight or flight. You're going to continue upper chest breathing because that is breathing. There's accessory muscles. You use those when you run from tigers or you're exercising, like you need a little more. But your body thinks it's running from tigers all the time. All the time, you're running from a tiger. There's no tiger. But your body thinks there is, and you're going around and around and around. Okay? Last chart on this, and then we'll be done with breathing pattern disorders. So the liver sits under the diaphragm, like this. I'm just going to use the liver. When the diaphragm goes down, it presses the liver down. It presses the stomach down. The liver moves 60 feet a day up and down in a normal breathing person. 60 feet a day up and down. The kidneys move a mile a day. Your intestines move a mile a day up and down in a normal breathing person. Now, if I take this motion away from the bottom half of you and I just put it up here, the liver, the kidneys, the intestines, they stop moving. Now, if I push the liver down, I'm literally squeezing that organ. What is your lymphatic system? How does your lymphatic system move? It's a muscle pumping system. The diaphragm is the main pump of your lymphatic system. So if you squeeze your liver, because it's going to squeeze against the organs below, you will squeeze out the septic fluids, like the cellular waste. Those fluids are coming out. And then as you open it up, it pulls fresh fluids in. And so that squeezing of like squeezing a dirty sponge, and you open it and get clean fluid in, and you squeeze a dirty sponge and get clean fluid in, that happens 20,000 times a day in all of your organs. And it's the diaphragm that makes that happen if you're normal breathing. Now, if your liver's not moving, what is the uterus doing? Because it's down this much farther. So if it's only moving this, is the uterus moving at all? Is there any lymphatic motion out of your pelvis? No, no. And so this is a big deal. This is a big deal, especially for women. I've never had a patient with fibroids or any problem in the pelvis, endometriosis, any of that, who did not have a breathing pattern disorder, and a pretty good one. And I'm wondering, I'm just going to throw it out there, is it because your lymphatic system is shutting down and your uterus is sitting in septic waste 24 hours a day, always? I mean, it's like trying to drink water out of a pond. Nobody will drink water out of a pond because we know that those are gross. If the water's moving and clean fluids are in and out, like in a spring, you would think maybe I can drink that, but not a gross septic pond, which is probably sitting in the pelvis. And so when you rehab breathing pattern disorders, people do get sick. They get nauseous. So they got to drink some water and try to dilute this as much as possible. So here's the upper chest lymphatic cascade. Okay, so your upper chest breathing right here, you got limited diaphragmatic excursion. Stomach, liver, kidneys, organs, lymphatic pump is not working. It's limited, right? So now you've got septic waste. So now everything's septic. The nutrients can't get in because there's no pump, and the waste can't get out. Your cells are sitting, their interstitial fluids, the fluid around the cell is just waste. Nothing can get in and out of the cell. The cell's just there choking. And so now the organs lose their mobility. They become sticky and they start sticking together because the fluids are getting kind of gunked up. That's going to cause more diaphragmatic excursion. It's going to cause, and you go around this. This is bad. Okay, so organs are septic. Vascular system slows down and becomes sluggish. Why? What vein, what blood in your body, venous system, doesn't go through the liver? The entire venous system at some point is going to wrap through the liver. The liver is 5 pounds. It's the giant blood organ. If that is bogged down, say my liver is bogged down, now I've got a traffic jam in the venous system trying to get more blood through and get it filtered and get it out to the heart and the brain, right? And so there's a problem there. And so the lumbar spine, its venous system feeds directly to the liver. And if your liver is bogged down, your discs are going to starve, and that's going to start herniations. You're going to have a weakness of the annulus, right? Or you're going to have hemorrhoids. You're going to have internal hemorrhoids for the liver, external hemorrhoids if it's a part of the mesentery. Just look at the anatomy. So if your mesentery is kind of bogged down, external hemorrhoids. If you have varicose veins in your legs, it's going to be through the portal system going through the liver. If the liver's bogged down because it's lymphatically clogged, then and it's septic, and you can't squish it and move it with the diaphragm, you're going to have all those symptoms, and you're going to lose your low back. You're going to have like herniation. You're going to have varicose veins. You see this on mothers. Now, if some woman is trying to get pregnant, really do the liver. Give her a good liver treatment if you know how. If you don't, get in touch. Let's figure it out. Okay, so that's what this is all about right here. Poor organ function. Well, now you're looking at your organs don't work. That's just bad all around. Poor circulation through the organs. Headaches, neck and shoulder pain from the organs. And if you get migraine headaches and it's not vascular here, the next thing you look at is the liver. The next thing you look at is the liver. And if it's not the liver, then you start looking at vascularization through the heart. But it's the liver, mostly. If there's right shoulder pain, osteoarthritis, some problem in the right shoulder, look at the liver. Postmenopausal women, they get right shoulder pain. It's their liver, because as they're postmenopausal, the hormonal cascade blocks the liver down, and the liver gets sluggish and it can't keep up. They start getting right shoulder pain. Okay, so that's the liver shoulder. This is the stomach shoulder. Left is stomach, gallbladder. Right. Okay, joint nutrition from the blood backs up. This is where the disc starts to degenerate. You get degenerative disc disease. Look at the vascular system. Is there blood going there? Okay. Degeneration of the joints themselves. That causes body pain. That's just going to stress you out. And there you go. Round you go. And so you're going around and around on all four of these charts. I'm not going to get too much into stabilization, but you are stabilized through the pressure system of the diaphragm from above. Right? It's hydrostatic, meaning you stabilize on the liquids, the pressure on the liquids within your belly cavity, right? Between the diaphragm and your pelvic floor. The squishing of the diaphragm comes down. The transverse abdominis and the two obliques are eccentrically loaded, and you catch that. So it's this and this at the same time, and that gives you pressure to stabilize your core. And it's why you hold your breath when you pick up something heavy, right? You also don't have that, right? And if you don't have that, if you don't have a stable core, then your hips are wobbling around, your shoulders are wobbling around. If your hips are wobbling, you're going to lose your ankles are wobbling, and you're going to have knee pain. The first thing that goes, if you have a patient with knee pain, it's a hip or ankle problem, and it's always a stability problem. Okay, so that's if it's chronic knee pain and they don't know where it came from. Okay, so that's breathing pattern disorders. Okay, so postural function of the diaphragm. Move this down so you can see. I'll give this thing away. Okay, breathing pattern disorders. Okay, all the symptoms of a breathing pattern disorder mimics fibromyalgia. So do you have fibro, or do you have a breathing pattern disorder actually? Right? Okay, so the breathing pattern disorder prevents proper head posture. It prevents equal tensions on all the muscles. Remember that chart, all the muscles that attach here? That ain't happening. Okay. It makes the lumbar spine very vulnerable to herniations because of vascularization and no stability, because you've lost both of those. And so there's no nutrition. And you're going to lose your hips and shoulders. So that's that. Okay. Okay. So, okay. Trigeminal nerve. We almost got this intro. Okay. The trigeminal nerve is the nerve where headaches occur, right? Very, very likely it's the trigeminal. Not always. There's no absolute in everything I'm saying here, but probably trigeminal. Okay, so it's the main sensory nerve of the head, the face, the teeth, the oral cavities, the nasal cavities, the whole anterior part of your head. People who have trigeminal neuralgia say, I have pain like a hand right here, right there. And look at the picture, right? It's the trigeminal nerve. That's not a hard one to diagnose. Okay, so important contributor of sensory inputs to the dura. Okay, trigeminal, it's sensory input to the dura. There's your pain. The sutures that line the dura, we're going to treat those. That's the first class. We're going to treat those. And it innervates the blood vessels of the cranium. We're going to treat those. And so the trigeminal is it, right? It's kind of the master nerve of your head, and it connects directly to the vagus nerve in your brain. And so is it really an extension of the, where does one end and one begin? I think they're just changing names, but when I'm looking at the body, you can't split these things up according to their names. You have to feel, test, and treat, and don't make any assumptions. Andrew Steele, if you have not read Andrew Steele's book, the original book from 1800s, is genius, and I don't know how he knew all that. But he says, you treat what you find, not what you're looking for. You treat what you find and not what you're looking for. Andrew Steele. The guy's a genius. And so what that means is, don't let your logic guide your hands. Let your hands find the problem. You find the problem, you use your logic to kind of understand it, and then you trust your hands. You trust your hands. And so you'll end up on places that are not even close to where the pain was reported. But when you're working on it, you'll be able to reverse engineer why you found that, right? And so follow your hands and trust your hands. But that's not a substitute for not knowing anatomy. You must know anatomy if you're going to do this kind of manual therapy. There's no way around not studying anatomy and not just naming the muscles. You got to know. You got to know how things are connected and spend a lot of time just looking at cadavers. So Gil Headley is my favorite cadaver lab guy because you can get a subscription and you could just go back and you can word search like parts of the body and you could go in and just watch, at your leisure, which I do. So I like Gil Headley because his interface is the best. Okay. Okay, what could go wrong if the trigeminal is overstimulated? That's what we're going to talk about, and we're going to wrap it up. Okay, so the trigeminal, I'm going to try to explain this. Okay, so there are 4 parasympathetic fibers, ganglias, associated with the trigeminal. They're up here, which isn't, and the whole parasympathetic, sympathetic, there's some holes in that theory. So just go with it for now, okay? So parasympathetic fibers reach their destination by joining the motor and sensory fibers of the trigeminal. Okay, trigeminal is involved in pain reception from the teeth, the dura, and the cranial vessels. All the stuff that we're going to look at in the first class. That's why we're doing this first. Stimulation of the ganglia. Right now we're talking about overstimulating the nerve. So these guys here. So if you put this PMID, you put that in the internet, you'll see the paper. That's what that's about. Okay, so overstimulation of the trigeminal ganglia causes release of substance P, which is the substance that causes pain, and certain neuropeptides. So if you overstimulate the trigeminal, you end up with pain in the teeth, the dura mater, and the cranial vessels. That's pretty important. Okay. Okay. And so here's this is like a little pro tip. I wanted to add this because a lot of people don't know this. If pain in the thoracic ganglia, this is around T3, at this ganglia, or the stellate ganglia, which is right there, C7T1 down in there, consider trigeminal hypersensitivity. And the reason why are these ganglias report to organs elsewhere. And I don't want to go way into that because we'll never finish. But if they have T3 problems, if it's like, oh, it hurts there, or it hurts here, there's pain when you poke in there, consider this trigeminal hypersensitivity and consider treating the trigeminal nerve for that. So treating it on the spot ain't going to get it, right? It's not going to get it. So that's just a pro tip that I found, and it's pretty cool. Okay, so according to these neurologists, this is just some other trigeminal facts, and it's good for you because you're going to have patients, as you get better, you're going to have more and more pathologies, more and more difficult patients. Okay, so 40% of the multiple sclerosis patients have neuropathy of the trigeminal nerve, right? They have here, their face is numb, tingling, maybe pain. Okay, 10% of those cases, it's their first symptom. Now, this is why we said earlier, if any facial stuff, get them to an MD first before you can work on it. You're not going to hurt them probably but you're not going to help them either. Don't waste their money. Patients like it when you send them away and don't charge them. They'll be back. Don't worry, because you're going to waste their time. Say, go see an MD because 10% of those cases, it's the first symptom of multiple sclerosis. And you want to get to these pathologies fast. And so let's rule that kind of stuff out, right? Okay, best results occur with migraines from front to back. So that's because of this trigeminal facts. So if it's front to back, it's a migraine, that's the easiest migraine to fix. It's trigeminal is getting yanked on. But if it starts in the back, it's getting pulled with structures that are very easy to reverse. So the front to back migraine is a piece of cake. Okay, the suboccipital nerve arises from the trigeminal ganglia. What does that mean? Okay, the suboccipital nerve goes right there. So you've got your trap attachment, SCM attachment, suboccipital nerve comes up, drops through the coronal suture. Now, you're not going to find that dropping through the coronal suture like if you look in Netters. But in a real body, it drops through the coronal suture. That's really important when you're treating because you have to release that entry point. Okay. And so people with trigeminal neuralgia, which is a really bad pain in their face, which is pretty intense. If you don't know what you're doing, God, get them to somebody who does. Right. That's this occipital nerve I found on at least 3 or 4 of them. It was the occipital nerve that was actually the key to relieving their pain. That's not even the trigeminal, right? I had another patient with a lingual branch. It was like stuck on like down here. And it was actually pulling on the nerve down here through the lingual branch here to the trigeminal right there. And so you treat what you find now you're looking for because the trigeminal didn't go where I was working, right? But we used the testing to find it. And the patient, we listened to the patient. He said, when I move my tongue that way, it makes my face go on fire. So then we just kind of searched it out and released it. But he was from out of town and it came back. And it came back because he needs the whole 7 processes. He needs breathing. He's got a breathing pattern disorder. And I found out he had a very traumatic event when he was childhood. And so that's the vagus. Vagus goes to trigeminal. So he needs the vagus treatment as well. So he had relief when he left, but it came back. So I had people flying in for this treatment. But it came back because I didn't have time to do the whole thing. And he didn't tell me about the trauma. And so now I just do the vagus right away. I mean, I try to get people in the vagus right away because a good solid vagus treatment, getting the brain and all that trauma out of your body it's the equivalent of like 5 to 10 regular treatments. It works so good, right? And it makes you wonder, like the source of all of our problems is just our brain. Okay, so pain lowering threshold. Nociception is pain. Noci is pain. Okay, these are the things that lower pain. And this actually is going to make sense in a second. Right? This is pain tolerance, right? Genetics, hormones. If you're a woman, you understand that. Digestive, your digestive system is not working, you'll experience pain as a greater because the vagus goes through all that. If you have food allergies, it drops your digestion. Weather conditions, barometric pressure, arthritis, people understand that. Electromagnetics, it does make people report pain more. Psycho-emotional trauma, right? If you're under stress, you're going to report pain more. Like you can't tolerate much because it takes willpower to maintain yourself during those events. Caffeine actually makes people report pain more. Trust of your therapist, that makes you like if your patient doesn't trust you, your treatment will be more painful than if the patient does trust you. And so I can come in the room and work on somebody and I'll do the exact same thing as like a student and it doesn't hurt. And I know damn well I'm doing the exact same thing. It's a level of trust, right? And so that's where you have to build that confidence so people trust you, right? And you have to have good results, right? Okay, when stress, anxiety, irritation, and anger go up, pain tolerance goes down. This leads to bruxing. Now we're back to trigeminal, okay? So bruxing is grinding your teeth at night. And I used to have this. I have mowed my teeth flat like a horse, cracked them all. And so, but I fixed that because now I do things that create joy in my life and I got rid of things that didn't. And that's a tough thing to do. You live in your truth and, you quit your job, you quit your career path and you change. And so that's why I'm here. Okay. So tooth grinding, all muscles of mastication are innervated by the trigeminal. Whoa. All muscles of mastication, chewing are innervated or activated by the trigeminal. Okay. So when you're bruxing, you're trying to massage, trying to put tension on the trigeminal nerve. Your trigeminal is overactive. You're hyperactive. Your trigeminal's up. You're like trying to smash on it, right? And that's what's going on. And so then you start smashing on it, and it starts getting more and more stuck back here behind your ear, deep in there. And so now now your jaw is locking down the trigeminal. And so when I rotate my head, I look down. I look this way. What's connected to the trigeminal? The vagus, the accessory nerve actually is all tied in there, and the great occipital nerve. Will I be able to do this if it's pulled this way? No. No, I'm going to have neck pain down here, this pain, that's all going to go off. They're the same. They're the same nerve. It's just that they just change the names, right? I appreciate the names because you know where to go. But during treatments, you got to throw those names out and look at where things are going. Like I have on my iPad pictures of the nerves. I have not memorized where everything goes. I look it all up. I have images, right? And I explain it to the patient in detail. Like you don't need to memorize all this stuff because you have resources. Just open a book, right? And like I'm going to give you a PowerPoint, a step-by-step process for venous sinus drainage. You do all 12 of those techniques, it's done. And eventually you're gonna feel the body and go, well, I don't really need this one. I don't need that one. Well, I need to add this thing. And then you'll suddenly start like getting away from the sequences we give you and start free flowing for yourself. But the idea is I'm going to give you a procedure that you can lay down and follow and do tomorrow. And somebody has a headache, you're going to be able to drain those sinuses and totally open up the venous system and get the blood to come out of their brain. Okay, so night guards, they don't prevent anything except for you cracking your teeth. They save your teeth, but they do nothing for the effects of this trigeminal munching. Okay. Okay, so we're almost done. Okay, so the vagus trigeminal relationship. Okay, trigeminal acts with the vagus nerve during social engagement. So that's your facial expressions. So the vagus is picking up information. Your trigeminal is changing the shape of your face. That's your expressions. Okay. Okay. And so trigeminal is a mediator between the vagus systems. And this is getting into the polyvagal theory, which I'm not going to talk about here because we'll never finish. And so if there's a problem with the trigeminal is in between the vagus. There's going to be a problem with your vagus system, your vagal tone. You're going to have a problem. And you can see why I put breathing pattern disorders in here with the trigeminal, because if your vagus has a problem, you're going to have a little more stress. You're probably going to be getting anxiety. You're going into the breathing pattern disorders. Okay. So what you can do for your vagus, your vagal tone, is I get the vagus treatment because that thing actually works. What we're doing really does work for trauma in the body. It does work. Deep breathing, rhythmic breathing to stimulate the vagal tone to try to calm yourself down. And then so the vagus can down regulate its excitability and then regulate the sympathetic to kind of tone it out and then calm the trigeminal, right? These trigeminal neuralgia patients, they need the breathing pattern disorder treatment as well. Okay, correcting the breathing pattern disorder calms the trigeminal, calms the headache, because the headache, trigeminal is where you're feeling the headache. Okay, so this is all tied together. Okay, so I added this because I like babies. Suckling in children. So that sucking action is stimulating, that's trigeminal is doing that. It calms the baby's sympathetic nervous system, the sucking action. And so that nursing is emotionally regulating the baby. And so our babies, when babies get hungry, they're, they start this, they go up and they start crying. And then if they get more and more ramped up, what's going on is their nervous system is getting deregulated. And then with the sucking action from that sucking action calms them down. And it could be the sucking action more than the food. You have those kids with like the binky, you put your finger in their mouth to calm them down real quick. And that works. So it's the actual sucking action on the trigeminal that calms the nervous system for babies. And so nursing, from the breast is best, right? If you could breastfeed a baby, you're going to have a much more resilient child. Okay, so here's abnormal conditions on the trigeminal. Sympathetic nervous system can be powerfully mobilized. You can go into sympathetic dominance. You can end up with fibromyalgia or undiagnosed fibromyalgia-like symptoms. Bruxism causes cranial and nervous dysfunction. Not only does it smash your trigeminal because you're trying to like massage it and just squeeze it, all the musculature of this is going to be asymmetrical and tight, and there's not going to be mobility or motility of your cranium. That's bad. right? That's real bad. Okay. Stimulates chronic digestive problems. I hope that's obvious. And then can lower immunity through sympathetic activation, because when you're in this hypersympathetic mode, your body's not fighting viruses or bacteria. It's running from tigers. Your immune system is downregulated, because why do you need to worry about a virus when you're chased by a tiger trying to eat you, right? The problem is your body always thinks there's a tiger, and then you're going into autoimmunity. This breathing pattern disorder, this stuff I'm talking about, trigeminal and all this whole relationship, can easily slip into an autoimmune problem. Easily. And anybody who has autoimmunity, they're going to have a breathing pattern disorder. I would bet lots on that. Okay. So trigeminal work should be included in the treatment of anybody who needs balance of the autonomic nervous system, anybody doing psychotherapy for stressors, any integrative medicine for autoimmunity, leaky gut, bowel, anything like that. Like if you're in an integrative clinic, look at these breathing pattern disorders, get Leon Scheitel's book. And currently, anybody who lives on Earth probably needs this trigeminal work, unless you've really done it already. Because, obviously there's a lot of stressors and people are pushing the stressors on us. So one more here. Okay, so this report, this is an iatrogenic effect from cranial treatments in 1996. Iatrogenic, that means you go to the doctor for problem A, they give you solution B, and solution B hurts you. So say you go to the hospital and they give you drugs and you have a reaction to the drugs and you die. That's an iatrogenic death. There are 750,000 iatrogenic deaths a year in the United States. So if you look up a paper called Death by Medicine, and it's actually available free online. They go through all these iatrogenic issues. There's MDs that ran this, and so anyway, these are people got hurt during a cranial treatment, and the cranial treatment they're doing here, I guarantee, is not cranial sacral where you're just like doing energetic work. It's like actually working on the bones and the structures. So that's what I'm doing, and that's what we're going to show. And so 2 cases were from intraoral treatments. All cases involved were excessive force by the practitioner. Okay, so take care with the working layer of the cranium, the veins, nerves, and arteries, especially inside the mouth. Now, the working layer. Okay, let me explain this because you can always pause and I don't have to worry about going long. Okay, so there's your skin. And if you don't know this, this is very important. I think I got this. I read about 90 books, but I think this is a Baral, one of his books. I read this in. So there's your skin. The skin's here. Now the working layer is how deep I can push before this pushes back. So if I push down, there's a point where everything starts to get hard and the lower part starts defending itself. Now there is no point in pushing beyond the working layer. You've got patients or your clients who want deep tissue massage. They've been trained this way. They think it has to hurt to work. They say, no, it's the thing that actually gets it. So on those people, what I do is I'll do like, say, this trigger point stuff here. I'll push on it. I'll fix it elsewhere. I'll push on it. And every time I'll go, is that better, worse, or the same? They're like, well, it's better. And I'll go work it. It's better. I'll work it. It's gone. And so I can change the way their brain perceives the manual therapy and get them out of deep tissue massage world. And they're like, oh, I'm actually better and it didn't have to hurt. Right? I've had patients come to me where tears because they couldn't stand the deep tissue work anymore. They just couldn't take it anymore. And they're like, can you do something to fix my back? Because I can't take it. I can't take it anymore, but it does work. So what you're doing is you're overpowering the system. What you want to do is be intelligent and work with it. If you go online, go on YouTube and watch this video, it's Strolling Under the Skin. And it's on YouTube. Jean-Claude Gimberteau did this, and he did scopes under the skin while the fascia moves, living fascia. And when you watch that, watch the fascia reorganize itself while this patient's moving their hand. Okay? And so what that's telling you is the fascia is a living matrix. It's alive in there. It has it responds to your pressure. Your brain is communicating through it somehow. Nobody knows, but it's alive and it's reorganizing and moving. You don't want to go in and force this tissue to do something it doesn't want to do. You can open it and allow it to change. That's what we're trying to do. And so the working layer is you push down until it pushes you back and you don't go farther. And then you work, and then you'll find the working layer gets deeper and deeper and deeper and then near to the bone. And the patient barely felt it, but their pain is gone, right? And so the working layer on the skull is shallow. It's super shallow, right? And so you don't have to push hard. There's nowhere to go, right? And so what happened in these iatrogenic injuries is people way over pushed, especially in the mouth. There's no reason to push hard in the mouth. There's no reason to push hard on the head. You have to back it off. And when you back off your pressure, you'll find that your hands like that a whole lot more. And you're going to have a whole lot longer career. And it really is worth learning as much as possible and extend your career as long as possible, because by the time you're 70, you're going to be awesome. You're going to be just like be awesome at this. And you're going to be the person to go see and the person who's teaching people. And we really need those people. We need this physical medicine out there. We need manual therapy to take hold. And it's the complexity of it. Manual therapy is very complex. So we're going to wrap this up. Safety tips, like all these techniques that are delicate. Anytime you're working on the neck or head, it's delicate. Test, treat, retest. Never assume it worked. Always retest. The patient knows it worked. You know it worked. You got to get patient buy-in because they can't really feel what you're doing. Doesn't feel like much. But if they can, their head is stuck and now it's not, that's patient buy-in. Okay, take great care of the cranium. Never do half a cranium treatment. That's why we're not giving you veins and arteries, because there's no way we can teach you veins, arteries, and the exercises all in 2 days. It's not possible. And so we want to give you veins and exercises. You take those out. Get good at those. You're going to get good results. People are going to like it. Then come back. Hopefully, if we get response, I'm going to do a more complex lecture. Come back. We're going to teach you the arteries from the heart up, right? And then the bones, right? All that stuff. And the way to fix concussions in head traumas and stuff. You got to work on the periosteum this way. Okay. And never do vascular releases above the heart without doing the veins first. Okay. So I'm assuming you don't know how to do the vascular releases above the heart. There's probably some technique I don't know about. We figured it out, right? I just used the principles that Mark Bookout gave me and I applied it and it totally worked. So we can do all the vascularization here. But I'll give you a story. I had an intern who has released all the blood vessels here on this woman who had chronic headache and some trigeminal stuff right here. And what happened to this woman, she had a balloon stuck in her nose. It's a chiropractors used to do this. They stick a balloon in the sinus, they blow it up really fast, and it's a sphenoid adjustment. Well, her palate broke in half, and she had like a couple cups of blood go down her throat. And so now she's got nerve impingement here. There's blood vessels, and the trigeminal is irritated because it's stuck in that. So now she's got chronic vagus, breathing pattern, all that stuff from that incident. So anyway, what this person did is we worked their heart. Well, I wasn't there. She worked the heart, all these vessels up because she was all stuck below, and her shoulders are working, and it was like a miracle. But she didn't do the venous sinuses of the head. And when all of this piping turned up, more blood flow, more volume, her head had to tolerate all of that more blood. So these big vessels were wide open. These were not. And now it's forced into her head. She felt great when she left. She woke up the next day with a burning halo around her head like this. It was terribly painful for 8 hours. What is the burning halo? Right? I knew what that was. It's the vascular system right underneath the skull. as they were getting more blood to it, they were forced open instead of doing it the other way where we treat it and allow the body to make its adjustment. It was forced open by your own blood. So you always do the venous sinus of the brain first so blood can get out before you go messing around with all this other stuff. That's why we're teaching it first. Also, it's powerful. It's a powerful treatment for headaches. If you have limited time, just do a normal scalp massage like you get at the hairdresser. You do shampoo, right? And don't try to half release a head. You're going to tear this person up, and it's so fragile. Don't try to move a bone unless you got time to make sure all the bones are organized, right? You don't just move the one that you know the problem's at, right? You have to do them all. And there's actually a very specific order that they have to be done in, right? Because they're coordinating together. Okay, trigeminal neuralgia, people do 50% release on the first treatment. Don't overdo these people. 50% is a pretty big relief for them, okay? Don't go like swinging for the fences and try to knock everything out of the park, because if it goes bad, it's going to go bad hard for these people because they're already in so much pain. So trigeminal neuralgia is like, it's a suicide disease. The part of the treatment is the doctors say, well, tell me if you think about killing yourself. It's like the worst toothache of your life that never goes away, right? And so be very careful with this, and always just go to coaching breathing, right? Okay, position of ease first. Always go away from tension first with the cranium and the dura. Dura likes position of ease. Dura does not like to be stretched. My experience, it likes to be mobilized. It likes that, but a continuous stretch, I don't like that at all. Your brain's pudding, right? You think that likes that? No, it doesn't like to be stretched. It likes position of ease. And so you put in position of ease, and if you watch that strolling under the skin, you can see like there's opportunities for the fascial systems to reorganize itself. So it's like tight. If I loosen it, they can finally like unknot, right? You want to loosen the knot with position of ease. Position of ease is going the easy way. So you put it the easy way, you wait 10, 20 seconds, whatever. It'll start going even farther into ease, then you're getting it until it kind of stops, and then you can go back into tension. And you'll find that you'll go a lot farther. You should practice this position of ease thing, because that's also is literally no work for you. You start using your brain and not your hands so much. Okay, use the cranial rhythm to enhance your results. There's an expansion phase and a contraction phase, right? And so that's a hands-on kind of thing. We'll explain how to use that. I use that all the time, and with the nerves especially. If you're working on the nerves, you got to time it, because the nerves are coming out of the spine, and 4 seconds later, they'll come in, and they'll do this. You have to time the body, time your treatment with the natural rhythms of the body, right? There's no forcing. There's no forcing. If you're using force, you're hurting your patient and you're hurting your hands, right? It's ignorant. You're going to have a short career. So why go through all this trouble to hurt yourself and go get a different job? You're just going to get better if you use your brain, okay? And so feel both sides of the head. There is no symmetrical head out there, right? So just because it's not symmetrical doesn't mean there's a problem. But feel both sides, but you want to palpate both sides. Now, cranium should be soft like greenwood meaning a bendy branch, like a fresh tree, not like a 2x4 or like this piece of plastic. This is hard, right? And so a cranium should not feel like that. It should have some give. All of these joints should have some give. If the cranium feels hard to you, that's hard head syndrome, according to Mark. He's marked the book out. And do your venous sinuses. Do your venous sinuses, and you'll find that the whole thing softens, right? You don't need to know the periosteum to get some results, right? That's why I'm going to give you the sequence. Working layer shallow, we did that. And then you're always treating the brain and the nervous system. You're always treating the brain and the nervous system, not the fascia, okay? Because what's telling the fascia what to do? What's telling the muscles what to do? The brain's actually in charge. That's why our brain vagus treatment works so well, because we're actually going to the brain and putting trauma in, and we're working with 2 therapists at once. And that's explained on our website. Okay, so that's it. We're musculoskeletal specialists. We are in Los Alamos. And I really mean this, that if you have questions, let me know. If you're going to go to the class, ask questions. Ask questions. I had a lot of questions going into this. I still have more questions than answers, but we're able to we'll be able to like solve some problems together. And so hopefully you can share this. If you're advanced, hopefully that testing information will help you get to the right place faster. And so I hope this was useful, and maybe we'll see you, me and Emily, or the rehab of the postpartum stuff. Don't underestimate how good that is. Don't ask. I don't even try to work on these women. I just give them over to these other ladies who are going to teach that class. They're going to show you how to do it. Okay, so thanks for participating. And if you made it this far, you should probably go to the class, because that's a lot. That's a lot. Okay, thanks a lot. You take care.